والصلاة والسلام على رسول الله. So thank you for organizing the committee for this kind of invitation. So management of heart failure in adults with congenital heart disease. So as my colleague discussed already, although that there is different figures, but let's say 0.4 of adults have some form, and 1/10 of that, these patients will have severe form of congenital heart disease. And obviously this will depend on the geographic region, like in Asia or in Saudi Arabia, like southern region. And again, it was mentioned that patients are catching up with better survival, and in 2000, number of adult patients with congenital heart disease exceeded the pediatric, the kids with congenital heart disease. And surgery is a cornerstone in management of complex congenital heart disease. And nowadays, 90% of congenital heart disease will be survived to adulthood instead of the 20% numbers in the pre-surgical era. However, this is very important to understand. Complete repair is extremely unlikely, and most patients with complex congenital heart disease are considered palliated. So some of the kids, the parents were told that your baby is fixed. Actually, they're palliated, and majority of patients are left with residual anatomical or hemodynamics abnormalities that predispose them to heart failure later on in their life. So in general, how do patients with complex heart disease present? As we heard, arrhythmia is very common, heart failure, stroke, infective endocarditis, and others. Just to remind you, they're normal. Even the best congenital heart disease patient, their normal peak VO2 as a measurement of their cardiac output and lung function are marked lower than normal. This is a normal, and this is a different spectrum and different diseases of congenital heart disease, and this is a normal for best congenital heart disease condition without being any sick yet. However, again, you can appreciate that symptomatic patients are more with complex disease, i.e. you can see patient with transposition has more heart failure than simple aortic coarctation, and the Fontan patient, most of them are symptomatic, and cyanotic patient, including Eisenmenger, are mostly symptomatic. Again, it was mentioned, patient at any time of their life, patient with mustard, which is congenital corrected transposition great artery, at any time of their life, there is a 22% of them will have heart failure. Complete congenitally corrected transposition great artery, up to 32% are in heart failure, and Fontan patients up to 40% will be in heart failure. So when do patients with complex congenital heart disease present with heart failure? So this is a range, multiple spectrum, multiple disease of congenital heart disease, but let's concentrate on the most complex abnormalities, such as tetralogy of Fallot. Usually their first presentation to the hospital will be at 34, at their 30s, and later on, 10 years later, they will present to the hospital with heart failure. If you look at transposition of great artery, again, the first presentation to into the hospital will be at 34, and with heart failure will be at 44. So i.e. this patient will present earlier in their life, and their heart failure usually by default is early in their life. This is after a spectrum screening for 83,000 adult congenital heart patient admitted in 1 year in United States. So, okay, so they presented early in life, they have early heart failure. Okay, so how do they die? So again, this is a spectrum of congenital heart defects, and again you can see the more complex the anatomy, like congenitally corrected transposition great artery, they die with heart failure, and later on, and a smaller group with arrhythmia. And double inlet left ventricle die again with heart failure. So the more complex the anatomy and the underlying defects, the more the heart failure will be the most common reason to die. So what are the mechanisms of heart failure in these patients? So chronic volume and or pressure overload, inadequate myocardial preservation during prior surgery in childhood, myocardial fibrosis, surgical injury to coronary artery, and pulmonary hypertension. All of these are predisposing factor for heart failure in these patients. However, as adults with complex heart failure, congenital heart disease get older, acquired heart disease and its risk factors become more frequent and contribute to the development of heart failure. Heart failure in adult congenital heart disease patients are less likely to be due to elevated systolic dysfunction as in patients with acquired structurally normal heart failure. Think about heart failure and congenital heart disease as a bimodal classification. We have systolic, we can talk about their systolic or diastolic dysfunction, and we can talk about anatomically, so this is physiologically, and this is anatomically. It's either their left heart will fail, right heart will fail, or their single ventricle will fail, and if it will fail, it's either systolic failure or diastolic failure. So risk factor for coronary disease, so their complexity predispose them to heart failure. However, as I said, as they are growing up, coronary heart disease are catching up, and the risk factor for coronary disease in adult congenital patients, including congenital anomalies, including origins and abnormal coronary artery courses, iatrogenic injury during previous repair in childhood, intentional manipulation during previous surgical repairs, such as reimplantation of coronary artery during arterial switch, operation for transposition of great artery, or root replacement in Marfan patients. And again, atherosclerosis as they get older. So all traditional risk factors associated with atherosclerosis are present in considerable number of adult congenital heart disease patients. So this is among the 1,976 patients, 82% were found to have at least one or more risk factor for coronary disease. Hypertension was present in 52, and dyslipidemia presents in 25. And this is as a screen across Europe in 2006. So 40% of adult congenital heart disease patients are overweight or obese, and most likely these are secondary to lack of exercise because of their condition, or because of us giving them wrong prohibitive advice. So all of these mechanisms will lead to exercise intolerance. So in our evaluation as a management in congenital heart disease, we have to have absolute understanding of underlying anatomy and previous surgeries, repair, and intervention. This is very important, and spending days looking for all the records, especially if it's done in other hospital, is a cornerstone in management of these patients. We have to look for anatomical dysfunction, residual shunts, baffle stenosis, valvular dysfunction, conduit dysfunction, and collateral vessels. And again, I can't stress more about looking for underlying arrhythmia, because the arrhythmia could be the precipitating factor for congestive heart failure. After that, we move on to as we usually do with our acquired patient, we screen for conventional cardiovascular risk factors, and if it's present, we can assess the patient. Does the patient need a cath? Does the patient need a stress test? The same way we do it with our acquired normal structure heart disease. So if the patient is symptomatic and presence of multiple risk factors, and our stress test is positive, again, patient should be cardiac catheterization should be considered in the evaluation of these patients. So in Toronto, where I got trained, 1% of adult congenital, it's considered one of the largest clinics in North America for congenital heart disease. So we did a study in 2013, and we found that 1% of our patients underwent cardiac catheterization for different reasons, and let's say 38% was they were asymptomatic from coronary artery disease perspective, or that's what we thought, but it was as a preparation for surgery later on. And the other indication was for either history of chest pain or previous history of MI. What we found, all of them almost have some sort, all of the patients referred for coronary angiogram, adult congenital heart disease, found to have some sort of coronary artery disease. And 14% of these patients were less than 40 years old, i.e. premature coronary disease are very common in this group of patients, the adult congenital heart disease group. So heart failure management, we have two models. We have the pump models, and I'm borrowing this from my colleague in structurally normal acquired heart disease. We have pump model and neurohormonal cardiac remodeling model. And in the pump model, heart failure is considered to be caused by dysfunction of one or both ventricles, pumps, and treatment is directed to improve the pump and or decrease the resistance that's acting against the pump. However, this is incomplete understanding and wrong direction. And this was the era where when beta blocker was contraindicated in heart failure. So now, we are moving, actually we are following the steps of our colleague in adult and structurally normal heart failure. And thanks God, we moved from the pump model, and because we understand that it's a neurohormonal, it's a neurohormonal and cardiac remodeling problems. And again, although it's small here, although it's not very clear, but I would say, okay, I don't know. Okay, I'm not sure how to direct this, but anyhow. So again, most of our patients in congenital heart disease, they have similar abnormalities in their neurohormonal system, and including abnormal BNP, ANP, norepinephrine, and etc. And okay. So some subsets of patients with other congenital heart disease, they have LV dysfunction, and identification and relief, again, as I said, we will look for anatomical obstruction. Identification and relief of residual obstruction and or regurgitation is very important. And conventional therapy like beta blocker, ACE inhibitor, spironolactone, etc., may have some role in other congenital heart patient with normal connections and no residual correctable lesion. And I'm going to just briefly talk about the three major complex congenital heart disease, including repaired tetralogy of Fallot, systemic right ventricle, and Fontan patients. And this is a tetralogy of Fallot, and medical treatment trials in tetralogy of Fallot post-surgery. So this is a beta blocker. And again, all of our trials are including a few 33, 40, 60, maximum 100 patients. So these are 33 patients followed for 6 months and randomized between bisoprolol and placebo. All of them were symptomatic, all of them has high BNP, and all of them has very low VO2 max of less than 25. Unfortunately, it's not that clear, but the echo and the MRI, this is an MRI data, MRI of the RV and MRI of the LV, parameters did not show any improvement in the RV or the LV dimensions or ejection fraction with the 6-month treatment of beta blocker or placebo. If we move to an ACE inhibitor, again, 64 patients randomized for 6 months for placebo versus ramipril. And again, you can see maybe there is some trend to improvement in RV ejection fraction, but it was statistically by far not significant.
Ahmed, 3 minutes left.
Okay, so moving on to systemic right ventricle. And again, this is a study done with ramipril in 17 patients, and again, did not show any improvement in the ramipril group compared to placebo group. This is the largest, best study done in medical therapy in congenital heart disease, including ARB in systemic RV, and they used valsartan, and it used 88 patients, and again, did not show any evidence of improvement. And however, there is a subgroup analysis showed that the symptomatic patient among these groups showed improvement in their RV ejection fraction. So the whole cohort did not show a difference, but symptomatic patient had improvement in their RV ejection fraction. So I'm going to take valsartan as an example in comparison to a normal cardiology population. So this study I was just talking about, the plan was to use a multicenter. So they use multicenter to include 128 patients. They were only able to include 88 patients out of 323 eligible patients. Young patients, they don't want to take medications. And among these 88, only 62 patients ended the study, and it was considered the largest and the best study with the longest follow-up, 3 years follow-up. And compare that to normal structure acquired heart failure, where they used valsartan, which is a VAL-HIF trial, and they enrolled more than 5,000 patients. So, and we only needed, in this study, we only needed 102 patients to show 80% power to detect difference in ejection fraction of 5%. So this could be, it's not like this medication is not really helpful in these patients, but basically these studies could be underpowered actually. Again, beta blocker, there's in systemic right ventricle. Some small studies showed some benefits. However, we have to be careful since many of these patients have underlying sinus node dysfunction. So besides statistics, what else can explain the failure of these medical managements? So incomplete understanding of pathophysiology. And again, as I'm saying, in heart failure, the improvement came after we understand it's not a pump failure issue, it's neurohormonal mechanism beside others. So for example, in patient with repaired transposition of great artery, where the RV is a subaortic, i.e. the RV is a systemic ventricle, there is a failure of atrioventricular coupling plus inability to increase the stroke volume with dobutamine stress. And this is limiting the stroke volume and cardiac output response. And it's an inherited Buffel problem. No matter what kind of medication you're going to give the patient, you will be unable to correct this problem. And in CCT-TGA, it's usually a valve problem, and patients who stay free of significant tricuspid regurgitation, and the tricuspid being the systemic atrioventricular valve in these patients, and they stay free of heart failure for decades of life. Again, I'm not going to discuss the details of Fontan, but just to show you, after Fontan surgery, after 5 years, the incidence of heart failure is remarkably increased, and I'm going to finish in 1 minute. And as you know, we discussed in patient post-Fontan, there is no subpulmonic ventricle, and pulmonary vascular resistance is a major determinant of circulatory output, and ventricular function is important only when it's severely impaired. And again, this is to show you that the cardiac output is in Fontan, this is compared to normal LV, and in Fontan patient univentricular heart, the more PVR, the higher the pulmonary vascular resistance, the less cardiac output you're going to have. So small studies of pulmonary vasodilator showed some promising results. However, larger and better designed studies are needed. Other therapy, including ICD, CRT, heart transplant, mechanical device. Unfortunately, we don't have time to discuss these. But again, there is no good evidence for these patients for these devices to help, especially in the primary prevention. ICD in secondary prevention, there is no. Obviously, it's indicated. Heart transplant is a major issue by itself, and it's very challenging to find the right patients. So what really works? So this is the most important slides. What really works in this patient? What do you think? It's not obviously surgery, as I mentioned, is a cornerstone, treating the underlying anatomical dysfunction. But what really works is referring patient to specialized center. This is just to show you a review in Canadian Journal of Cardiology, and recently in 2014, just to show you this is a number of deaths. However, the number of deaths in patients actually remarkably improved despite patient getting older by referring them more and more to cardiac centers specialized in adult congenital heart disease. So in summary, heart failure in adult congenital heart disease are less likely to be due to left ventricular systolic dysfunction as in patient with acquired heart failure. It is usually due to RV dysfunction, valve dysfunction, or shunting. Conventional heart failure may have a role in symptomatic patient. Heart failure in adult congenital heart disease carries worse survival. Large and well-designed trials are needed. Large and well-designed trials are very difficult to be done, and referral to specialized center is crucial for these patients' well-being and survival. Conventional risk factor modifications are required in all patients. Thank you very much.